Good morning, everyone. We're going to talk about the Southcentral Foundation Nuka model of care. The objectives of our talk are to describe the Nuka model of care as an example of a community with disadvantages who have taken over their health care and created a world-class system of health care. We also want to talk about what's wrong with healthcare and what needs to change, and we want to show the Nuka model of care is a model that is sustainable and successful, and it's based on customer-driven care. So a little bit about Southcentral Foundation. We've been around for 25 years. Our system of healthcare, it's innovative, it's relationship-based and customer-driven. We have over 14,000 staff. We have 140,000 statewide clients. We have 55,000 local clients right in the area where we live, including 10,000 in over 50 remote villages. We're part of Alaska Native Medical Center, which is a hospital and outpatient health facility. The hospital's 150 beds. We have over 400,000 outpatient visits per year. We have local primary care. We're the regional community hospital, and we're also the tertiary care statewide hub for Alaska Native people. At Southcentral Foundation, we have family practice, primary care, women's health, pediatrics, optometry, dental, behavioral health, including residential treatment program, outpatient treatment programs, elders programs. We have an innovative program called Family Wellness Warriors, which is dealing with abuse and neglect. We have tribal doctors and traditional healers. We also have acupuncturists, massage therapists, and chiropractic care. So why do you want to listen to our story? What do we have to say? Well, we, have based our healthcare on what our customer owner values are, and we've actually created a system that works very well. We have shown generational changes reducing family violence. We have decreased our urgent care and ER usage. We have decreased hospitalization. We have decreased our specialist utilization and even decreased our primary care utilization based on our model. We benchmark against national organizations, and we use HEDIS, and we score in the 75th to 90th percentile in all our measures on clinical care. We have great satisfaction from our customers and from our staff. We have very, very little turnover, and this is in an urban Alaska Native community that has huge challenges. So the United States Congress said to us at one point, they said that they had caused some of the conditions that created the healthcare system that we had and the disparities that were there. And then they also said that if Indian people were to take over their own healthcare, they would probably do a better job and improve health statistics. And so they asked Indian people if they wanted to take over their healthcare. And we said, yes, we do want to take over our health care. But we actually had another choice. So we had two choices. Did we want to take over our own health care? And then the second choice is once we took it over, what were we going to do with it? And we chose to change it completely. We did a total redesign, and we based it on Alaska Native values and on what our elders told us to do. We put the customer owner in control at all levels of the system. So when we took over from Indian Health Service, we inherited a system that was very poorly funded. There was poor infrastructure. It was bureaucratic. It was slow. There was weak primary care capabilities, and nobody was happy. So Southcentral Foundation actually redefined its base. So from the 1980s, it was based on the customer focus, and then eventually it went into a deeper listening of our customer and from customers and from our staff, and then we redefined our mission and vision and key points and launched our primary care system. This is our president and CEO, Catherine Gottlieb. You can see the mission is about working together with a Native community to achieve wellness. And the vision is a community that enjoys physical, mental, emotional, and spiritual wellness. Key points are shared responsibility, and that includes with the individual and the family. And it's a commitment to quality, giving quality health care, and also family wellness. We recognize that the family is the center of the Native community. Our operating principles are all around relationship and emphasis on the well-being of the whole person. We want to create a system that is designed around the customer owners and how they access care. So we have open access. We have an intentional redesign of our whole system. We bring services to our customer owners. We try to make them as simple and easy to use as possible. We base everything around quality measures. We look at our population health, and we build all of this around the Alaska Native culture.
Morning. So Donna's kind of laid out some of how we got to where we are, who we are, and how we think. And to a lot of Alaska Native people, particularly the elders that we were listening very closely to, this just made a lot of sense. That this business of these operational principles and the relationship-based way of thinking, a lot of the people in the community just went, well, yeah, that's how we live life. But we had to apply this to a medical system. We had to take those operational principles that changed vision and mission, and we had to translate it into a delivery system that made sense. And most of our staff, at the time we took over, were non-Native people, and particularly the medical professionals, for the most part, were non-Native people. Even those who were Alaska Native, such as Donna, had gone through medical school and residency and so forth, and had been trained into a whole different medical culture and medical way of thinking. We thought we were pretty good at this project-based kind of stuff, where we'd fix this, and then this, and then this, and we'd apply this kind of fishbone cause and effect diagrams and all this kind of stuff. But it wasn't until Alaska Native people took over the system fully and completely in 1997 and 98 and 99, kind of gradually over those years, and they came in and said, fine, you're doing some good stuff here, but the system is fundamentally wrong. The whole basis, the underpinnings of the system are wrong. And we insist that the system be rebuilt upon what the customers, the customer owners, the Alaska Native people want, and that the professionals adapt to what they wanted rather than the other way around. Does that make sense? And I'm going to tell you that this isn't just about customer control, but it's actually about producing good medicine, good healthcare, good outcomes, and good value for money. So it's not just about making people happy, it's actually a much, much better designed system. And we went from project-based, fixed little pieces of the system to whole system transformation. And if there's anything about the SCF Nuka model of care story, that's the part that you need to take home with you. So before I jump into my favorite diagram, let me make one more illustration that maybe kind of helps make the point. Don Berwick, who was the head of IHI for over 20 years and is now the head of CMS for the US, Center for Medicaid and Medicare for the US, has a story he likes to tell, and Don knows I do this, so I'm not being too offensive to Don or anything, but he has this story. He talks about a car, and he had this car, I think it was a 10-year-old Toyota or something. He took it out on this flat stretch of road, and he put the accelerator down, and its top speed was 105 miles an hour. And no matter how much Don yelled at the car or encouraged the car or gave it pay for performance or anything else, the car would not go faster than 105 miles an hour because it was engineered to produce exactly what it was producing, right? Every system is designed to produce exactly what it's producing because by definition, that's what it's producing. So Don's story is, his analogy is, in order to change the car, you have to change the parts of the car. So you have to fix the transmission, you have to change the tires, you have to put in a new engine, you have to use different oil and different gas, and eventually you can make a car that can go 150 or 200 or whatever miles per hour, right? Nice visual analogy, makes sense. And I love the analogy, but for very different reasons than Don does. Don uses it to show that if you're going to improve health care, you have to go back and re-engineer piece by piece the healthcare system in order to get a different healthcare system in the end. Sounds good, right? Well, kind of, if your purpose, if your goal is to make the car as good a car as it possibly can be. If your goal is to make healthcare as good as healthcare can be, just go in and fix the parts of healthcare and you'll get a better healthcare. But let's go back to what the purpose of the car is. The purpose of the car is to transport people from point A to point B, right? And if all you do is fix the car, all you will ever have is a car. But if you have 500,000 people to move from point A to point B, maybe you need a train or an airplane or a boat or something like that. And if all you need to do is run to the grocery store for a loaf of bread and come back, maybe you need a bicycle or a set of cross-country skis or something like that. If all you ever think about is the car and how to make the car better, all you will ever have is a better, faster, safer version of the car. But if you understand its purpose is to transport people from point A to point B, you back up, you start to think about that purpose, and you allow yourself to get outside of the limits of a car, you can come up with whole different ways of transporting people from point A to point B. And it's probably obvious what I'm trying to do here, but healthcare's purpose is not the sustaining of healthcare. It's not maintaining the perfect version of the wrong model or a limited model. It's to improve the health of populations of people longitudinally over time, period. If that's true, then how we do things may be good for some parts of what we're trying to do, but not everything we're trying to do. If you're trying to transport people really efficiently, you probably do need some cars, but you may need some bicycles and some skis and some trains and some airplanes. You may need a whole range of different transportation options for different purposes at different times. Same thing in healthcare. Instead of being stuck in one model as we have been for 75 to 100 years, depending on when you think the modern medical model started, instead of using that for everything, maybe it's just one piece of what we really need to get a whole population to better health over time. You with me? Okay. If you're going to try and change the health of a population longitudinally over time, if that's your purpose, you need to understand not just the philosophy that we're going to try and do health, not health care as our central purpose. You need to then understand what are the levers you have to pull. Where are you going to exert change? And again, our elders told this right away when we started talking to them. When we took over the system in 1997, 98, 99, the first thing we did was sit and talk to Alaska Native people at great length. For 6 months, we just listened. And at the end, we created these things called expectations of an idealized healthcare system, which eventually became our operational principles, which Donna showed you a few minutes ago. But one of the things they said is what this diagram shows, which is basically that the people in control of health outcomes longitudinally over time are not the professionals, but the people who have the health status issues, okay? So that's what this shows. If you look at the diagram, on the vertical column is percent, 0% to 100%. So if you have two lines, they have to be inverses of each other, right? And then along the continuum on the bottom is low acuity to high acuity. So in high acuity situation, I get hit by a car on the street, I'm laying there unconscious, EMS scoops me up, they do a bunch of things to me in the ambulance, they take me to the ER, they do a bunch of things, they take me to the operating room, they do a bunch of things, they take intensive care, and they do a bunch of things. And in that setting, it's a very high acuity setting. I may even be unconscious, but at a minimum, I have relatively little to say about what's going on, and the system has a lot to say. So the patient has low control, the system has high control in a very high acuity situation where many decisions have to be made quickly to save a life. Okay? And I'm okay with that. In that setting, as long as my wishes overall are being followed, i.e. I want to be rescued, then that's a good thing. However, today, somewhere around 80% of the people and 70% of the money in healthcare is not on that end, it's on this end over here. Low acuity settings. So I'm talking about low acuity inpatient, which is most inpatient care. Talking about medical offices, behavioral health, school clinics, nursing homes, assisted living, all kinds of residential treatment programs. The biggest part of chronic condition management and all of these things that we do in all of those categories of care are on this end, the relatively low acuity situations. And in those environments, the overwhelming power and control lies in the hands of the patient or the customer owner and their family or the immediate people around them. And this isn't whether we want to give them control, it's they already have control. So to illustrate this for primary care, because this is kind of a primary care conference, if I'm a doctor and someone comes to me in my office, we do our little thing in the office and then I send them on their way. And whether they go pick up their medications is under their control. It's surprising when you study it how many people actually don't even pick up their meds. Once they pick them up, how they take them is under their control. Do they cut them in half so they last longer? Do they pull out the pill bottle from last time because it helped me before, probably going to help me this time? Do I share with Donna because if it worked for me, maybe it's going to work for you? Or I quit taking it in 3 days because now I feel better, so I don't need them anymore. Or I quit taking them in 3 days because they have side effects, I don't feel so good, they're hurting me, so I don't take them anymore. All of those things are under the patient's control or the customer owner's control. Whether they exercise, what they eat, whether they drink too much alcohol, whether they smoke, whether they use their walker, whether they use their inhaler. All these things that drive whether you get chronic conditions to start with and how well you live with them once you have them, almost completely the actual decisions day to day that decide whether they're going to get chronic conditions and how well they live with them are almost completely under their control. Anybody disagree? No? Well, if that's true, my question to you, especially if you're in primary care, is then why the heck are you perpetuating that system? Why do you get up every day and go to work and keep doing that system, which is, if you look at it rationally, for what it is you're trying to do, makes no sense at all as a way to change health for a population over time. If I stand here and throw something at a target across the room, and I'm active, and the thing I'm throwing is a rock, it's an inanimate object. Over time, I can eventually hit the target every time. Through practice, through observation, through measurement, I can have a team of people analyze the arc and the wind and all that kind of stuff. I can install best practices, I can have people come and coach me, and eventually I can hit that target pretty much every single time. I'm active, it's passive, eventually I can do it by replicating exactly what I do to standard by protocol every time I can hit the target. However, if what I have in my hand is not a rock but a bird, I can aim it, I can send it with force in the right direction, but whether that bird ends up at the target is overwhelmingly in control of the bird. So kind of like healthcare, right? That high acuity situation in that other slide is like throwing a rock. On this side over here, low acuity, it's like throwing a bird. Now, I can make the target more attractive to the bird. I can put bird seed, I can put a house over there for the bird, I can put its babies over there. I can start to understand the bird, what motivates the bird, and do something about the motivators and have the target connect to the motivators for the bird and have a higher chance of getting them to go. But at the end of the day, the bird's in control, and my best bet is to get to know the bird and understand the bird and do something with the bird to help make the target more attractive to the bird. Just throwing it harder with more force isn't going to get me a whole lot of gain. It's extremely important then when you do improvement work to know whether you're in an environment where you're throwing a rock or you're throwing a bird, because your tools, your methods, and your product you're after, and the whole way you manage variation, change in your staff and the whole process is going to be very different in a situation where you're throwing a rock versus throwing a bird. And in healthcare, we think all we do is throw rocks. We think it all should be protocolized and standardized, and somehow magically everything's going to break out. And we've been doing this for almost 20 years. This is this project-based stuff that Brian was mentioning a little while ago. We need to be very, very good at that. We need to apply it where it makes sense, but we need to understand complex adaptive systems and managing people in complex adaptive systems if we're actually going to really make a difference in this a little bit mushy, gushier stuff that happens to be about 90% of what we do in primary care. All right. So the bottom line in healthcare, that longitudinal platform we call primary care, we believe is a service industry, not a product industry. We're throwing a bird, not a rock. They're in control, we're not. It's our job to adapt to them, to understand them, to support them on their terms, in their places, on their timeline, with their models and not ours. We're a service industry, not a product industry. We need to quit benchmarking all those product industry people. So this Toyota, Six Sigma, whatever, it's good stuff when you have a rock situation, but not when you have a bird situation. We're a service industry where relationship is the primary product. So how we select people, train people, and all that kind of stuff needs to be changed as a result of that. Let's meet Frank. He's 79 years old. He has COPD, heart failure, diabetes. He lives alone. He's anxious. He's very breathless. He feels unable to manage. He phoned his primary care, blah, blah, blah. He's called 911 a whole lot of times, have been admitted 7 times in the last year, and even has a little suitcase by his chair just in case he needs to go to the ER. We have a lot of Franks. You don't have any Franks, right? Oh, you do have some Franks. Well, all you need is a protocol and a standard and give him his pills and he'll be fine. So medical lingo. Frank has COPD, CHF, and diabetes. He has all these providers who, of course, coordinate perfectly across all the boundaries for Frank, right? Why are you laughing? Aren't you spending your whole entire professional life perpetuating this system? I'm dead serious. So here's the reality. Frank is in control. Frank is in charge of whether he gets his pills or not, uses inhalers. Frank's in charge of how he eats and sleeps and exercises, socializes, and Frank's in charge of whether he dials 911. You have very little influence. He's costing us a ton of money. No one really knows Frank, and he's getting worse. Now, if you look at our system, the Nuka model of care that we've perpetuated and developed and perpetuated SCF, we would say Frank's primary diagnoses are anxiety, loneliness, isolation, insecurity, confusion, dependency, and lack of confidence. Those are his medical, clinical, primary diagnoses. And I want an ICD-9 code to be circled for that, and I want to be paid for that. I'm dead serious, because if you don't fix those, the fact he has COPD, diabetes, and congestive heart failure, it almost doesn't matter. If you don't fix the primary diagnosis, you will not make progress with the secondary diagnosis. Therefore, in our system, the primary interventions are personal care coordination, integration of care by an integrated primary care team, determining his motivators, behavior-based motivational interventions, consolidating his meds, connecting him to social service programs and other things like that. We'll visit Frank again at the end of the talk. But this is a radically different way to understand Frank and what the primary things are that need to be addressed and where we need to spend most of our time and energy and money and where we need to be paid by the payers to do this work. This is a current healthcare system design. All a bunch of pieces living in parallel. The customer has to go, or the patient has to figure out how to go between them, and they all work as pretty much separate islands. And I've done work in Canada, almost every province, many countries in Europe, all over the South Pacific, all over the United States. And I can tell you, and I've lived and worked in Latin America and Africa, and I can tell you that everywhere that our westernized medical model is in place, that this is the correct diagram of the medical system. So here's a summary statement. Primary care must change. It's the most failed part of the medical system. And I'm tired of hearing primary care people complain about being victims. Woe is us. We don't have status. We don't have privilege. We're paid terribly. Everyone dumps on us. Everyone blames us. Woe is us. Woe is us. We're the victims. The customer has no power and control in changing health care. The government and other payers want to buy a good product, and we've provided them a crappy product. Are the colleagues in healthcare just looking out for their own turf? If the system's going to change, the people who run the longitudinal platform called primary care have to change the longitudinal platform called primary care. It's up to us in primary care to change it. And playing the victim and blaming other people hasn't worked for 20 years, and it just makes us look stupid. And in the US, this whole business of the patient-centered medical home has gotten some currency, but so far it's coming off as looking like a bunch of primary care doctors trying to get more money to keep doing what they've always been doing. That's a new approach in healthcare. Make me richer. Remember, the patients are in control. We're a service industry. It's longitudinal relationship over time, and the patient should decide what success looks like. And at the end of the day, this is what they should be able to say. They give me what I and my team have defined, what I need, when, where, and how I want and need it in a safe, effective, and optimized way. They really know me and care about me. They listen to me, advise me, support me on my journey, my entire health journey. My questions and concerns are answered. My care is coordinated. My values and goals are what drive my health plans. And if the people in your system can give you a 10 on all of these things, then you've succeeded in designing a system that works. The point here is not to exactly replicate the SCF Nuka model of care. It's to understand the philosophy, the discussion, the way of thinking, the priorities, and then get a glimpse at how we have operationally structured it in a little bit of way. And you just got a glimpse today. We actually prefer that you come and live with us on our land in our system for 3 to 5 days if you really want to fully understand us and what we've done at every level of our system, because this isn't simple. This isn't one little change or two little changes. This is changing everything in an entire healthcare system, and that's extremely hard work that takes a long time.